Welcome to our March ICPEDS entitled, Muli Nating Tutukan ang TB-DOT sa Timog Katagulugan, an online CPD on childhood tuberculosis. This CPD aims to discuss the recommended approach to diagnose TB in children, explain effective and complete treatment of all TB cases, implement TB preventive measures, emphasize adequate recording and reporting of all TB cases, apply knowledge to certain clinical scenarios. TB remains an urgent public health problem in many parts of the world. WHO estimates the annual global burden of TB in children in 2012 to be 530,000, and that up to 74,000 children died from TB. Substantial efforts to improve TB care and control have been made by means of Direct Observation Treatment Strategy, or DOTS. The creation of childhood TB subgroups in 2003 triggered increased advocacy and attention to childhood TB. Administrative Order Number 178 of 2004 set the guidelines for implementing TB control program in children. This has been revised to include changes in program indicators, introduction of new diagnostic tools, changes in case definitions based on WHO guidelines. Case finding is the identification and diagnosis of TB cases among individuals with signs and symptoms of presumptive TB. The current approach to case finding includes: first, passive case finding, when symptomatic patients are screened for disease activity upon consult. Second is intensive case finding. This is active case finding among individuals belonging to defined populations like close contact, one who shared an enclosed space during 3 months before commencement of current treatment, among high-risk clinical groups, particularly those with immune-compromised states. This includes malignancy, autoimmune diseases, or patients on prolonged systemic steroids. Or high-risk population, those living in congregate settings such as orphanage, boys' town, temporary shelters for calamity victims. Presumptive TB is a child with signs and symptoms of TB. For 15 years old and above, at least 2 weeks cough with or without weight loss, fever, hemoptysis, chest or back pains, easy fatigability, or dyspnea. Or cough of any duration if a close contact of active TB disease, or among high-risk clinical groups or high-risk population. For patients below 15 years old, at least 3 of the following clinical criteria: cough or wheeze of 2 weeks or more, fever of 2 weeks or more, weight loss or failure to gain weight, failure to respond to antibiotic for respiratory infection, failure to regain previous state of health after a viral infection, or reduced playfulness. Any one of the said symptoms in a child who is close contact of a known active TB case, and in a child with radiologic findings of pulmonary TB with or without symptoms regardless of age. Presumptive extrapulmonary TB or EPTB refers to TB involving organs other than the lungs like larynx, pleura, lymph node, bones, joints, and meninges. Presumptive EPTB may have any of the following: gibbous, resulting from vertebral TB, non-painful cervical lymph node with or without fistula, signs and symptoms of meningitis unresponsive to antibiotics. Pleural effusion, pericardial effusion, distended abdomen with ascites, non-painful enlarged joint, signs of tuberculin hypersensitivity like plictennular conjunctivitis and erythema nodosum. Direct sputum smear microscopy, or DSSM, is fundamental to the detection of infectious cases. All presumptive TB patients should undergo DSSM unless not possible, like mentally incapacitated patients, debilitated or bedridden patients, children unable to expectorate, or even adults unable to produce sputum despite sputum induction. The only contraindication to DSSM is massive hemoptysis. Blood-streaked sputum can still be examined. 2 sputum specimens of good quality should be collected either spot 1 hour apart or spot early morning depending on the patient's reference. DSSM positive if at least 1 smear is positive for AFB. DSSM negative if both sputum smears are negative for AFB. Tuberculin skin test, or TST, only trained health worker may do the testing and reading, read and interpret between 48 to 72 hours from the time it was administered. It is used as a screening tool for children and shall not be used as a sole basis for TB diagnosis. A 10 mm induration is a positive TST reaction. Gene Expert Mycobacterium tuberculosis rifampicin assay is a rapid molecular diagnostic test endorsed by WHO that detects Mycobacterium tuberculosis and rifampicin resistance. Specimen can be sputum, gastric washing, or even CSF. Gene Expert MTB, RIF are reported as follows. For the TB disease classification, pulmonary TB can be bacteriologically confirmed. A biological specimen is positive by smear, microscopy, culture, or rapid diagnostic test. Pulmonary TB can be clinically diagnosed if a patient who does not fulfill criteria for bacteriologic confirmation but has been diagnosed with active TB by a clinician. This includes cases diagnosed on the basis of X-ray abnormalities or able to fulfill 3 out of the 5 criteria for disease activity. For EPTB, can either be bacteriologically confirmed, positive specimen for AFB either by smear, culture, or Gene Expert. Clinically diagnosed, histological, clinical, and radiologic evidence consistent with extrapulmonary TB, and the decision by the physician to treat with anti-TB drugs. This is the diagnostic algorithm. All presumptive TB shall undergo DSSM. If sputum is positive, classify as bacteriologically confirmed. If negative, for patients 15 years old and above, do a chest X-ray. If the X-ray is normal, investigate further. But if suggestive of TB, refer for Gene Expert. However, if there is no access to Gene Expert, the physician will use his clinical judgment to decide if active TB, or the physician may opt to refer to a specialist or to TB Diagnostic Committee or TBDC. If anyone decides to treat as TB, the patient is clinically diagnosed pulmonary tuberculosis. For patients below 15 years old who are DSSM negative, refer for Gene Expert if positive, bacteriologically confirmed. But if negative, investigate further. For patients who cannot expectorate sputum, for DSSM or Gene Expert, do a TST. If negative, do a chest X-ray and decide to treat as active TB if the child has 3 out of the following diagnostic criteria and be classified as clinically diagnosed TB. If the child does not fulfill 3 out of the 5 diagnostic criteria, investigate further or refer to specialist. Screening of household contacts of TB cases. All symptomatic contacts shall be evaluated based on the previous algorithm. All asymptomatic household contacts, more than 5 but less than 15 years old, shall be re-evaluated once with signs and symptoms of TB. For less than 5 years old, contacts of clinically diagnosed cases, do a TST. If negative, child is for re-evaluations once with signs and symptoms of TB. However, if TST is positive, give isoniazid preventive therapy or IPT for 6 months. On the other hand, for less than 5 years old contacts of bacteriologically confirmed cases, do a TST. If negative, give IPT. If TST is positive, request for chest X-ray and rule out TB disease. Case holding under directly observed treatment strategy provides constant supervision to ensure treatment compliance. This works by having a treatment partner to watch the patient take the anti-TB every day during the whole course of therapy. Usually, it's the nurse or the midwife in TB-DOTs. Or, in managing pediatric patients, it can be the mother or the teacher. TB disease registration involves assignment of patient based on anatomical site, history of previous treatment, and bacteriology confirmation. New case is one who has never had treatment for TB or who has taken anti-TB drugs for less than a month. IPT is not considered as previous TB treatment. Retreatment for those previously treated with anti-TB for at least 1 month in the past. Under retreatment is relapse, a person declared cured or treatment completed for TB and is now diagnosed with TB. Treatment after failure includes patients whose DSSM is positive at 5th month of therapy and those who does not show clinical improvement anytime during treatment. Treatment after loss to follow-up are patients who is lost to follow-up for 2 months or more. Previous treatment outcome unknown. Outcome of the treatment is unknown or undocumented. Others, if person who does not fit into any category cited. Anti-TB treatment regimen shall be based on anatomical site and bacteriologic status, including drug resistance and history of previous treatment. Category 1, for bacteriologically confirmed or clinically confirmed new cases of pulmonary and extrapulmonary TB cases, 2 months of isoniazid, rifampicin, pyrazinamide, and ethambutol, followed by 4 months of isoniazid and rifampicin. Category 1A is for more severe forms of extrapulmonary TB. Here, we give 2 months of isoniazid, rifampicin, pyrazinamide, and ethambutol, followed by 10 months of isoniazid and rifampicin. Category 2 includes retreatment cases of pulmonary and extrapulmonary TB. Treatment is 2 months of isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin, followed by 1 month of isoniazid, rifampicin, pyrazinamide, and ethambutol, and then 5 months of isoniazid, rifampicin, and ethambutol, for a total of 8 months of therapy. Category 2A, for retreatment cases of severe extrapulmonary TB, the treatment is 2 months of isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin, followed by 1 month isoniazid, rifampicin, pyrazinamide, and ethambutol, followed by 9 months of isoniazid, rifampicin, and ethambutol, for a total of 12 months of therapy. All retreatment cases should be screened for drug-resistant TB and referred to Programmatic Management of Drug-Resistant TB or the PMDT. Standard regimen for drug resistance, like rifampicin-resistant TB, or multi-drug resistant TB, meaning resistant to both isoniazid and rifampicin. Treatment includes pyrazinamide, kanamycin, levofloxacin, prothionamide, and cycloserine for at least 18 months. For XDR-TB or extensively drug-resistant TB, in addition to isoniazid and rifampicin resistance, these patients are also resistant to fluoroquinolone and to at least one of the second-line IV drugs, like kanamycin, amikacin, and treatment of these categories are based on drug sensitivity test and previous treatment. Dosages of anti-TB drugs. The dosages for children are higher since there are more metabolizing enzymes among children than adults, leading to faster metabolism. If the patient is a newborn, meaning less than 4 weeks of age, streptomycin can be used instead of ethambutol. Treatment response of PTB shall be monitored by follow-up DSSM. Do DSSM at the end of intensive phase, on the 5th month, and on the end of treatment. For Category 1, if smear positive at month 2, obtain sputum again at month 3. If positive, declare as treatment failure and refer to PMDT for DRTB screening. For Category 2, repeat DSSM at month 3, then on month 5, and at the end of treatment. If smear positive, refer to PMDT. For extrapulmonary TB and for pulmonary TB patients whose DSSM was not done, treatment response will be assessed clinically. Weight gain, resolution of symptoms, and if the patient does not show clinical improvement, reclassify as treatment failure. During follow-up visits, closely monitor the occurrence of adverse reactions to drugs, especially during intensive phase. These are possible minor reactions that should be managed appropriately. These are major adverse effects that necessitate withdrawal of the responsible drug. Once the adverse reaction to a drug is confirmed, the offending drug must be replaced with another drug. For patients with major adverse reactions to all first-line drugs, refer to DOTs with PMDT services. Treatment outcome. Determine the treatment outcome of patients based on completion of treatment regimen, DSSM follow-up results, and clinical improvement. Cured are patients bacteriologically confirmed TB who is now smear negative culture at the end of treatment. Treatment completed are bacteriologically confirmed TB who has completed the treatment but no repeat DSSM done, or clinically diagnosed patients who completed the treatment. Treatment failed patients of DSSM positive and still positive at the 5th month or later, or patients clinically diagnosed who does not show improvement during treatment. Died, person who dies during treatment for any reason. Lost to follow-up, patients whose treatment was interrupted for 2 consecutive months or more. Not evaluated are cases transferred to another DOTS facility whose treatment outcome is unknown. Prevention of TB depends mainly on preventing exposure and infection. TB prevention can be achieved through universal use of BCG. All infants should be given a single dose of BCG except those who are known to be HIV positive, those whose HIV status is unknown and is born to HIV positive mother, and those who have signs and symptoms of HIV. Isoniazid preventive therapy or IPT for 6 months shall be given to patients less than 5 years old without signs and symptoms of TB, without X-ray finding of TB, and is a household contact of bacteriologically confirmed case regardless of TST. However, if they are contacts of clinically diagnosed case, initiate IPT if TST is positive. Start isoniazid at 10 mg per kilo for 6 months. While on IPT, assess child every 2 months. Check for signs and symptoms of TB. Weigh monthly. Adjust dosage accordingly. If the child develops signs and symptoms of TB anytime during IPT, evaluate according to case-finding procedures. Outcome of IPT will be recorded as follows. The risk of the baby being infected with TB is highest if the mother was diagnosed with TB at the time of delivery or shortly thereafter. Assess the newborn. If not well, manage accordingly. If well, give IPT for 3 months. After 3 months, do a TST. If negative, give BCG and stop the IPT. If positive, continue IPT for 3 more months, and after 6 months of IPT and the baby remained asymptomatic, give BCG. If TST is not available and the baby is well, give IPT for 6 months, then give BCG. Recording and reporting are important in implementation of a successful TB control program. Through this, we can monitor that each presumptive TB is treated and cured. TB among children has been called the hidden epidemic. The disease has been underreported. Addressing this hidden epidemic has been our recent focus. Our society is launching the TB registry, which could strengthen the national reporting of TB occurrence in children. Please wait for further announcement regarding this. Referral system aims to reduce the delay in diagnosis and treatment of TB cases. Policies on referrals are as follows, wherein the rights of the patients, responsibilities of the healthcare providers, as well as the referring and receiving facilities are stated. This is Form 7, or the referral form. All rural health units and city health centers are providing TB services for drug-susceptible TB. For drug-resistant cases, these patients are assessed at PMDT treatment centers in public or private hospitals, health centers, and rural health units. The major reasons for referral includes for TB diagnosis, for initiation of treatment, continuation of treatment, management of serious adverse reactions, screening for MDR, TB, and screening of TB among persons living with HIV. As pediatricians, you must recognize that there is still more than it needs to be done. As Dr. Lincoln said, whenever there are tuberculous adults, there are infected children, and no one is immune. Eliminating TB in children is possible but requires sustained advocacy. TB ay kayang tuldukan, kaya. Please answer the questionnaire on the questionnaire page of this site, all for the Filipino child.